Good morning, everyone. Today I am here to present my seminar on the topic of factitious, malingering, and somatoform disorder. And my moderator is Dr. Sumit Mehta, sir. We will study these topics under the following headings. First of all, we will study introduction, then definitions, then history, then nosological evolution, clinical presentation, assessment, management, and overlap issues. Non-specific symptoms that are not explained by organic pathology are extremely frequent in the general population and also in medical settings. Most are transient, but a substantial minority is persistent, disabling, and often associated with frequent consultation, especially when there are multiple unexplained symptoms associated with psychiatric disorder. They are very difficult to treat. Factitious, malingering, and somatoform disorders have similar presentation in terms of symptomatology, psychodynamic basis, psychodynamic basis, associated factors, assessment results, and phenomenology. They are separated by thin boundaries of consciousness and motivation, often not appreciable. We lack substantial research in these fields. All three can be a riddle in forensic circumstances and pose a challenge to therapist or clinician. Classification of factitious, malingering, and somatoform disorders have been a matter of debate for eras, though the prevalence is significant, but small portion is visible for psychiatrists. Factitious disorders. Factitious disorders are those conditions in which individuals actively create signs or symptoms of physical or psychological disease. Primary motivation is not avoidance of duties, financial gain, or anything concrete. The motivation is simply to receive medical care and to partake in the medical system. Malingering is intentional false presentation, which can be invention, gross exaggeration, or otherwise gross misinterpretation of symptoms or health problems with primary goal of attaining an external reward. External gain may be financial incentive, for example, compensation, but it may also relate to obtaining drugs, escaping from formal duties like sick leave, military services, sitting in an exam, legal responsibility or punishment, or obtaining other material or non-material advantages. Somatoform disorder. In this, patients with somatic symptom disorder believe that they have some severe yet undetected disease, and evidence to the contrary does not persuade them otherwise. They may maintain a belief that they have a particular disease, or over time may transfer their belief to another disease. They are fixated on one or more of somatic symptoms that they are convinced are evidence of illness. This is the ICD-10 classification of somatoform disorder, which F45 is somatization disorder, then is undifferentiated somatoform disorder, hypochondriacal disorder, somatoform autonomic dysfunction, and then persistent somatoform pain disorder, other somatoform disorders, and somatoform disorder unspecified. Primary gain. Primary gain can be a component of any disease producing positive internal motivations. That is, it's a constituent element of illness in which the stressor manifests themselves as physical symptoms without organic causes, which leads to psychological relief. Most typically, it is demonstrated in the Malingering disorder. Secondary gain, it can also be a component of any disease, but is an external motivator. If a patient's disease allows him or her to miss work, avoid military duty, obtain financial compensation, obtain drugs, or avoid a jail sentence, these would be examples of a secondary gain. It is an addition to primary gain, which comes to play at later stage. These may but need not be recognized by the individual and can be unconscious psychological component of symptoms and other personalities. Quite often, there are elements of primary and secondary gain occurring at the same time, which are difficult to understand and delineate. Tertiary gain, it is when a third party, such as any relative or friend, is motivated to gain sympathy or other benefits from illness of the victim. History of factitious disorder. Cases of factitious disorder appear in the medical literature as early as 2nd century AD. The term factitious is derived from a book by an English physician named Gavin, published in 1843, entitled On Feigned and Factitious Diseases. The modern study of factitious disorder began with a 1951 article in Lancet by Richard Asher, coined the term Munchausen syndrome to describe a chronic subtype of factitious disorder. The name Munchausen syndrome comes from an 18th century German baron who liked to embellish stories of his military exploits in order to impress his listeners. Gellenberg first reported a case of factitious disorder with primarily psychological symptoms. Factitious disorder was recognized as a formal diagnostic category in DSM-3 in 1980. The most notorious factitious disorder is Munchausen syndrome by proxy, in which a mother creates illness in their children. This condition is a form of child abuse and is handled in the criminal justice system. History of malingering. Post-traumatic neurosis, a diagnostic precursor of PTSD, was proposed in 1882 in reaction to industrial railway accidents, with simultaneous recognition that this could lead to false claims for compensation. In the late 19th century and early 20th century, introduction of workers' compensation led to numerous derogatory terms such as compensation neurosis to describe the suspected malingering. Military malingering came into picture during the First World War time with enabling of new insurance acts from the late 19th century in European and North American countries. During Second World War, the British dropped pamphlets over German troops instructing them how to feign injury in order to obtain military leave. History of somatoform disorder. Somatic presentations that have a presumed psychological origin have always mystified the medical establishment and have taken new forms and shapes as cultures evolve and medical paradigms shift. Throughout the ages, multiple folk concepts and terms have been used to designate the phenomena such as hysteria, hypochondria, spleen, English malady, humoral disorders, neurovegetative dysfunction, neurasthenia, neurovegetative dystonia, and psychosomatic disorders, and many others. Idea that psychological processes are involved in these somatic experiences appears to have ancient origin, waxed and waned periodically. In the 17th century, Thomas Sydenham attributed symptoms and signs such as convulsions, diarrhea, and dropsy to the disturbance of the mind. Psychoanalyst Wilhelm Steckel used the term somatization for the first time in 1911, defining it as the bodily expression of deep somatic neurosis or the process of how neurotic conflicts are presented as physical symptoms. Nosological evolution. Bricket syndrome, first described by Paul Bricket in 1859, in which patients feel that they have been sick most of their lives and complain of a multiple symptoms referable to numerous different organ systems. Conviction of illness persists despite repeatedly negative and unrevealing consultation, hospitalization, and diagnostic procedure, and patients continue to seek medical care, to take prescription medicines, and to submit to needless diagnostic procedure. DSM-1 in 1952 listed dissociative reaction together with conversion reaction in a section for psychoneurotic disorders that also included anxiety, hysteria, and depressive reaction. DSM second in 1968 listed hypochondriacal neurosis within a section entitled neurosis. DSM-3 in 1987 introduced phenomenological and theoretical St. Louis criteria for Bricket syndrome. Diagnosis of somatization disorder as defined in DSM-3 required a lifetime history of 14 out of 37 possible symptoms, reduced from requirement of 25 out of 59 possible symptoms for the diagnosis of Bricket syndrome. Name somatization disorder was adopted, and this disorder anchored its somatoform disorders category. It included conversion disorder, psychogenic pain disorder, hypochondriasis, and atypical somatoform disorder. Separated DSM-3 separated dissociative from somatoform disorders and group conversion with somatoform disorder. The dissociative disorder section was placed immediately after the somatoform disorder to reflect the recognition of a conceptual proximity of these two groups of syndrome. DSM-4 and DSM-4-TR major changes were the criteria for somatization disorder was further simplified to 8 symptoms from a list of 32 symptoms distributed among 4 symptom groups. The section on factitious disorders was inserted between somatoform and dissociative disorder. DSM-5 in 2013, somatoform disorder criteria was reconceptualized in a new section of somatic symptom and related disorder. Somatization disorder, hypochondriasis, pain disorder, and undifferentiated somatoform disorder were dropped. Term malingering has been deleted from index and is treated under the headline non-adherence to the medical treatment. Eliminated the factitious disorder section and moved its content into the section for somatic symptom and related disorder. ICD-9 in 1978 included dissociative, conversion, and factitious disorders together in single category. Separate categories were provided for somatoform disorders, depersonalization disorder, and hypochondriasis. Thus, conversion was included with dissociation and separated from somatization. ICD-10, it retained the previous edition's classification of conversion and dissociation together and separate from the somatization. ICD-11 offers a new landmark opportunity to bring functional disorders back within the legitimate domain of neurology. They have proposed a category within a neurologic section in which all of the functional disorders involving motor and sensory function can be listed and quoted. Clinical presentation of factitious disorder. These individuals may produce factitious physical symptoms as a response to stressful life situation that exceeds their usual coping strategies. Individuals may produce serious medical problems, but in addition, travel widely, appear to be highly sociopathic, and have a history of unceasing patienthood. Gains often include motives such as getting cared for or reducing guilt over angry or sexual feelings. What makes factitious disorder so difficult to understand is the common misunderstanding of the concept of primary gain and the fact that the secondary gains appears to be relatively small. Virtual factitious disorder. Although virtual factitious disorder does not appear as a heading in any present diagnostic manual, it is phenomenon that has appeared with increasing frequency with the spread of the internet. Growing use of computer allow people with sufficient technical skills to access medical records from hospital databases and edit to their own records in order to falsify their medical histories. Computers also allow people to enter chat rooms for persons with serious illnesses and pretend to be a patient with that illness in order to obtain attention and sympathy. Munchausen by internet can have devastating effects on chat groups, destroying trust when the hoax is exposed. Clinical presentation of malingering. In malingering, most of the individuals act to create signs or symptoms of a disease, although main motivation is to obtain some secondary, external, or material gain. Keen observation would be able to understand the malingering behavior by knowing the individual circumstances and material reward the illness would bring. Suspecting malingering goes in the favor due to lack of cooperation with the diagnostic evaluation and lack of compliance with prescribed treatment regime. Presentation with a medico-legal context, palpable external gain like avoidance of military duty, financial compensation, presence of antisocial personality disorder, drug-seeking behavior attributed to an unrelated etiology. Clinical presentation of somatoform disorder. Main feature of somatoform disorder is repeated presentation of physical symptoms together with persistent request for medical investigation. In spite of repeated negative findings and reassurances by doctors that symptoms have no physical basis. If any physical disorder are present, they do not explain the nature and extent of the symptoms or distress and preoccupation of the patient. Patient usually resists attempts to discuss the possibility of psychological causation. There is often a degree of attention-seeking behavior. Psychological basis of factitious disorder. Psychodynamic explanations have been proposed for factitious disorders, which include patients with factitious disorder are trying to reenact unresolved childhood issues with parents. They have underlying problem with masochism. They need to be center of attention and feel important. They need to receive care and nurturance. They are bothered by feelings or vulnerability. Receiving a physician allows them to feel superior to an authority figure. Three concepts of psychopathological etiology of factitious disorder by proxy are: it may be conceived as secondary manifestation of a primary psychopathological entity or personality disorder. Learning theory emphasizes operant rewards received from vicarious sector. Attachment theory provides possible explanation concerning the traumatic impact on the child, early sources of psychopathology, and fabricating mother, and risk for intergenerational transmission of factitious. Psychological basis of malingering, models of malingering behavior. The adaptational model of malingering proposed by Rogers asserts that malingerers engage in a cost-benefit analysis during the assessment. Malingering is most likely to occur when context of the evaluation is perceived as adversarial, the personal stakes are very high, and no other alternatives appear to be viable. Psychological basis of somatoform disorder. In classical psychodynamic drive theory, medically unexplained physical symptoms are believed to develop as a reaction to the repression of unacceptable wishes or instinctual impulses and internal psychic conflicts. According to theory of self-psychology, anxiety connected with a threatening defragmentation or disintegration of the self is most profound form of anxiety that a person can experience. In a defense mechanism against the feeling of emptiness, the individual becomes directed on the outside world and on physical stimuli. This process can be called as stimulus entrapment, meaning that in somatization disorder, the individual becomes addicted to stimuli to his or her body. The cognitive theory endorses the importance of the patient's misinterpretation of benign symptoms and normal physical sensations that they erroneously attribute to a physical disease. Diagnosis of factitious disorder. By the very fact of shifting from one physician to another, factitious disorder patients make it difficulty for any one physician to accurately assess them. Clinicians should become suspicious that patient may be fabricating symptoms if the following features are noted. The course of illness is atypical and does not follow the natural history of presumed disease. Physical evidence of a factitious cause may be discovered during the course of treatment. Patient may eagerly agree to or request invasive medical procedures. There is a history of numerous previous admissions with poor outcome to respond to surgery. Many physicians have been consulted and unable to find a relevant cause for the symptoms. DSM-5 have named it as factitious disorder, and in ICD-10, it is intentional production or feigning of symptoms or disabilities, either physical or psychological, factitious disorder. Symptoms according to DSM-5, factitious disorder imposed on self and factitious disorder imposed on another. In factitious disorder imposed on self, patient fabricates their symptoms and clinical findings, claim to be ill, purposely misleads health professionals, no apparent external reward or motivation outside of the illness role. In factitious disorder imposed on another, as above, all the features are same as above, except the object of feigned illness or injury is another person. Exclusion criteria, any other mental disorder, and course specifier like it is divided to single episode or recurrent episodes, two or more discrete events. In factitious disorder imposed on another, the perpetrator receives the diagnosis, not the victim. According to ICD-10, symptoms includes feigned symptoms, no apparent external reward or motivation, aim is to take on the sick role, and it excludes factitious dermatitis and malingering. Diagnosis of malingering. Identification of defendants who are malingering or feigning psychiatric disorder is a complicated and difficult process. In routine ward-based evaluations, malingering is mostly diagnosed with support of clinical history, mental status examination, physical and neurological examination, proper investigation, collateral information, discrete observation of the patient during the assessment period, and repeated clarification of discrepancies. Differentiation by forensic psychiatrists and psychologists of those respondents who are feigning psychiatric symptoms with authentic mental health difficulties have typically depended on a combination of psychometric and clinical history presentation variables. Diagnosis of somatoform disorder. General principles of assessment include: consider psychological factors from the outset, use appropriate physical investigation to exclude physical cause, clarify psychological and physical complaints, clarify previous personality and concerns about physical illness, understand patients' belief and expectations, identify depression or other psychiatric disorder, identify psychological problems. Diagnosis of somatoform disorder. It has been classified according to DSM-5 as somatic symptom disorder and according to ICD-10 as somatization disorder. Duration more than or equal to 6 months is included in DSM-5 and more than or equal to 2 years in ICD-10. Symptoms according to DSM-5 are patient will be preoccupied with symptoms and their potential seriousness, anxious about symptoms and health, time and energy devoted to the symptom, symptoms needed more than one or equal to one. In ICD-10, it is recurring symptoms frequently change, prolonged involvement with the medical system,